All right, guys, 6:30, right on the dot here. So we want to welcome you to a very special orthopedic and multidisciplinary webinar here tonight, run by NYU Langone Health. My name is Vinay Agarwal, and I'm going to be our course director for this really unique opportunity. I have a star-studded cast that I have been able to corral and put together here to give their thoughts, their opinions, and really their advice to build a multidisciplinary team in treating orthopedic-related infections. And the title is periprosthetic joint infection, but really we're talking about all orthopedic infections. And so I'm going to run through the agenda here. And I'm really happy that we have everybody contributing from their expertise. This is kind of what we're going to go through: microbiology, diagnostics, effective surgical debridement tools and techniques, using local antibiosis and irrigant solutions, and soft tissue coverage. Can't forget our plastic surgery colleagues. Finally, wrapping it up with how to choose the right antibiotic, working with your ID colleagues. And we have a really, really special group here today. We're going to have two parts that I'm going to open up to question and answer. One is going to be at 7:30 when we break for some questions, both to our panelists and hopefully from the audience. So please feel free to be as involved. Send your questions in via the chat. I'll take a look at all of those and get as many of those answered as we can. And then we'll have another question and answer session at 8:15 before we adjourn at 8:30. A little bit of a longer webinar. I actually pitched to try to get this a little bit past the 1 hour mark because of how much material we have to cover, and also because of how much knowledge and expertise we want to disseminate from our five panelists. So without further ado, I'm going to introduce everybody. Keep in mind that today's audience is not just orthopedics. We have infectious disease, we have plastic surgery, and hopefully on the audience, we have PAs, nurse practitioners, RNs, micro, pharmacy, OR staff, and many, many more colleagues to help get educated. So without further ado, I do want to go through our audience members here tonight. And our panelists begin with Sarah Hochman. Dr. Hochman is our NYU infectious disease representative of co-director of the antimicrobial resistance pathogens programs. And she has a significant topic she's going to cover on microbiology and microorganisms. Next, we have Mort Mefta, also from NYU Orthopedics as an orthopedic surgeon, does a lot of infection work and is director of the Center for Innovations. Another one of our orthopedic surgery colleagues, Armin Arshi, is joining us. He's an NYU Orthopedics Brooklyn campus surgeon, does a lot of surgeries in Manhattan as well. He's going to be talking to us on local antibiosis. Vin Pham is chief of infectious disease at our NYU Orthopedic Hospital and member of our faculty at NYU Infectious Diseases, and is going to be talking about which antibiotics to choose. And then Pierre Sade, our plastic surgery member. Pierre, I tried to look for any pictures and I came across this prom photo of you from the internet. So appreciate you letting us use this for tonight. But looking handsome as always. You're going to talk to us about soft tissue coverage. And I'm looking forward to seeing the hundreds of pictures before and after that plastic surgery has to offer us. So without further ado, let's begin. And we're going to get started with Dr. Hochman talking about microbiology one-on-one. What are the most common organisms? And really a topic that I think is important to understand from our perspective, both as orthopedists and across the community, is, are all these organisms the same? And if not, what are the nuanced differences? So Sarah, go ahead, take it away.
Great. Thanks so much for having me. And I am going to talk about some of the most common organisms that we face with periprosthetic joint infection. I'm having, now I can advance the slide. So this is an outline of what I'm going to cover. I'm going to talk really briefly about the pathogenesis of periprosthetic joint infections, or I use the term PJI a lot throughout this. I will talk about the spectrum of pathogens that contribute to PJI and some of the differences in those organisms based on the joint that's affected. And then I will talk about the pathogenicity of some of the most common organisms, and it'll correlate somewhat with how that impacts treatment decisions. So first, pathogenesis. Infections in the joint can occur through multiple mechanisms. So they can occur through direct seeding. either during the time of surgery or if there's delayed wound healing after surgery. And these infections tend to come in the first 3 months. These are bacteria in the environment or on the skin or mucous membranes that then get in and then can cause infection. Infections can also be spread through hematogenous routes, so there can be a bloodstream infection which can then seed the joint. These tend to occur not during the first 3 months after surgery, but really at any point after the fact. And then there are patients who've already had an infection in the affected joint, and we frequently worry about recurrence of infection. And these can occur really at any time, but most frequently within 12 months of that prior infection being treated. Another component of the pathogenesis of PJI is the fact that these joints have foreign material in them. And so when there's foreign material in the body, the amount of bacteria needed to cause infection is significantly less. And so in the case of joint replacements, the bacterial concentration needed is 100,000 times less than if it were a native joint. So that's an important component of the pathogenesis. And really along with that is the biofilm formation that many of these bacteria and even Candida species can exhibit. So pathogens adhere to the prosthesis. They create colonies that are then encased in this matrix. And this matrix is made up of proteins, lipids, sugars, some genetic material, some enzymes. And that matrix really protects the pathogen from many of the host defenses and also makes it a lot harder for antibiotics to get in there and to kill the pathogen. Next, I want to talk about some of the most common organisms that are seen in prosthetic joint infections. And so I'll first talk about knee arthroplasties. This is data from NYU from 2023 and 2024, just showing the breakdown of organisms that contribute to knee PJIs. And so Staph aureus, both methicillin susceptible as well as methicillin resistant Staph aureus, make up about 60–70% of the cases of periprosthetic joint infections in knees, followed by, and I lumped these together, gram-negative bacteria, and then coagulase-negative Staph species. So coagulase-negative Staph species are things like Staph epidermidis, Staph capitis. These are organisms that are typically found on the skin. The pathogens for hip arthroplasty PJIs are a little bit different. Not surprising, so Staph aureus, both MRSA and MSSA, still make up together the largest proportion, but gram-negative organisms are a big chunk. We start to see more streptococcus species, enterococcus infections, as well as polymicrobial infections when hip arthroplasties get infected. So it's a little bit broader spectrum than in the knees. And this can be a reflection of the different bacteria that are found colonizing the skin around the center of the body as opposed to what's colonizing the skin lower down. And then lastly, when it comes to shoulder arthroplasties, the bacterial spectrum is even more different. And again, this reflects really the normal bacterial skin colonization of the upper part of the body. So this is not data from NYU. This is data from a database involving multiple surgical centers with over 1,400 shoulder arthroplasties. And among these surgeries, the most common organisms that were identified with PJIs of the shoulder was Cutibacterium acnes is number one, followed by coagulase-negative Staph, and in this case, Staph epidermidis, and then Staph aureus with about 15%. There were another smaller proportion that had other organisms or no organism identified. So it's a very different spectrum, and these are things that we take into account, the ID doctors take into account when we're recommending empiric antibiotics. So now I'm going to go into some of these most common organisms, the ones that we worry about when it comes to periprosthetic joint infections. And so among the gram-positive organisms, we have Staph, Strep, and Enterococcus. They all are gram-positive cocci on gram stain, meaning they look purple and they're like little balls. but the pattern of how they clump together or line up is different. So with Enterococcus and strep, they both have gram-positive cocci that are in pairs and chains, and I have two representative images of those on the right. Staph aureus tends to be clusters. Coagulase negative staph looks identical under a gram stain to Staph aureus and also is in clusters. Staph aureus has many virulence properties that I'll go into some of them, and they can cause invasive infection even in healthy people. Coagulase negative staph lack many of these virulence properties, and they really only cause infection in the presence of foreign material in the body. So I'm going to talk a little about Staph aureus and why it's such a problem. So something to keep in mind with Staph aureus is that colonization of the skin and mucous membranes is very, very common. When we look at patients who are admitted to the hospital, somewhere between 20 and 25% of them have asymptomatic Staph aureus colonization in the nose. One of the reasons why Staph aureus can do that is that it creates a lipase that degrades fats and oils in the skin that promotes colonization. Another key component of the pathogenesis of Staph aureus is that colonization frequently precedes invasive infection. So the fact that so many people are colonized with Staph aureus prior to surgery predisposes them to, can predispose them to invasive infection after surgery. And then once Staph aureus does get through the skin or mucous membrane barrier, it has multiple virulence factors that promote infection. And the graphic at the bottom right shows some of these, but they exhibit several binding proteins that allow it to bind to host proteins. They also have different toxins that they can release and different enzymes for invasion. So their adhesion proteins promote attachment both to host cells as well as prosthetic material. Some of the toxins include pore-forming toxins. There's also super antigens that can trigger a very intense immune response. There are proteases that degrade host cell proteins and that allow the inflammatory response to spread. Staph also produces staphylokinase that promotes spread of bacteria. And then they also have hyaluronidase that break up the extracellular matrix that can also induce inflammation. So I think one of the hallmarks of Staph aureus infections is there's a very robust inflammatory response, and many of their virulence factors promote that. Coagulase negative staph species like Staph epidermidis share some of the same virulence factors as Staph aureus, and really the ones that relate to adhesion. So Staph epi and other coagulase negative staph species have adhesion proteins that promote adhesion both to the host cells as well as prosthetic material, and they help foster creation of biofilms. They also have polysaccharides that foster the attachment to prosthetic material, and then also helping with adhesion or teichoic acids. And this graphic is really showing kind of the process from initial adhesion to maturation, where they form a biofilm that can make them difficult to clear. The last two gram-positive organisms that I want to talk about are Enterococci and Streptococci. Enterococcus species, their virulence factors really focus on promoting adhesion and biofilm formation. So just like staph, they have adhesion proteins. They also have proteases that can mediate the biofilm formation. And then they also have, what kind of sets them apart from staph species is that they have different antimicrobial resistance mechanisms, and many of these are mediated through efflux pumps, and that can make it a lot harder to treat Enterococcus, and why it sometimes requires 2 different antibiotics to treat. For streptococcal species, these virulence factors also promote adhesion and biofilm, and then some species like group A strep or strep pyogenes have additional toxins that can cause significant inflammation and tissue damage. But I think what's important to take away from Enterococcus and Streptococcus, along with staph, is that these are commensal organisms. So Staph aureus, coag-negative staph, they're commensals on our skin and our mucous membranes. Enterococcus and Streptococcus species, they're commensal organisms in our alimentary tract. So strep is often found in the mouth, Enterococcus in the lower GI tract, And so these are organisms that we live with until something happens where they leave where their normal habitat is and then get into a habitat where they can cause infection. So now I'll talk about gram-negative organisms, and I'm not really singling any of them out, in part because they make up a smaller proportion of the periprosthetic joint infections, but they have some different virulence factors. So they are less likely to form a biofilm that makes it harder to treat, but they have different factors that allow them to attach to host cells and prosthetic material. So, for example, some gram-negative organisms have pili that allow these bacteria to attach to host cells and to the joint replacement. Another important factor with gram-negative organisms is that compared to many of the gram-positive organisms, they have very high rates of antimicrobial resistance genes. And so this can make them harder to choose empiric antibiotics, and then can also make it more difficult to treat them long-term because we have fewer antibiotic options. Lastly, many gram-negative organisms produce lipopolysaccharide, or LPS. This is an endotoxin that promotes a very robust inflammatory response that can also promote infection. And then I have to put in an honorable mention here for Candida species. They make up a very, very small proportion of periprosthetic joint infections, but when they occur, they're very difficult to cure, and they tend to occur in patients that are already difficult to treat. So their virulence factors really focus on adhesion and biofilm formation, as well as the fact that they're dimorphic, so they can switch forms between hyphal and yeast forms. And these tend to occur in some of our highest risk patients. So patients who are immune compromised, either because of malignancy or treatment for malignancy or transplant. They are more likely to occur in patients undergoing revision arthroplasties, as well as patients who already have a history of treatment for periprosthetic joint infection. And so that's kind of an overview of some of the most common organisms that we see and some of their pathogenesis that makes them difficult to treat. Thank you very much. And these are my references.
Okay. Perfect. I'm going to take control here, Ian. Well, thanks so much, Sarah, for that overview. I felt like I was back in, first year of medical school. That was exactly what I wanted to go for there. Learning about kind of the differences between each of these organisms that actually, all of us encounter, whether you're in orthopedics or, plastic surgery or ID, or hospital-acquired infections for people without orthopedic hardware. But certainly in orthopedics, each of these plays some kind of different role. And that last one you ended on, I was going to ask you a question about that during the Q&A, but you kind of answered it there, that Candida species, we say once a fungal infection, always a fungal prosthetic joint infection. So these are very, very, very bad actors. And it's interesting to see that data that you presented on the breakdown of our numbers. We've seen here at NYU, thankfully, an evolution and hopefully a decrease in the resistance profiles over time, which is something that we're going for thanks to the hard work of you and your team. So appreciate you guys. And, like we always say in orthopedics, if you're early, you're on time. So with that, we're going to move to the next talk here about diagnostics, which is me. So I'm going to spend the next 10 minutes talking about making the diagnosis of prosthetic joint infection. So there's a lot of acronyms out there. You all may have heard some of them, MSIS, ICM, all these different things you may hear at orthopedic national conferences. I'm going to tell you a little bit about how we got to this point and where we are today and where we might be going in the future. And certainly the way we do things at NYU. And hopefully that can give you, at your practices, whether you're at NYU or somewhere else, a little bit of an appetite into maybe what might work for you in the future going on with diagnostics. So diagnosis comes down to having, obviously, what we tell all of our medical students, residents, fellows, et cetera, is it starts with clinical suspicion. All right. If it smells like an infection and it looks like an infection, you ought to work them up for an infection. So don't bury your head in the sand. That's the first thing we tell people is going to fail your boards. Make sure you have a clinical suspicion and go after it thereafter with lab data. And the lab data that's important has evolved over time. And we're going to talk about what I use and what a lot of my colleagues at NYU use for laboratory workup. Clinical suspicion starts with a joint that may or may not look like this on the right, but there is progressively worsening pain. Usually patients have previously well-functioning joints. So if you've done a hip or knee replacement, or if they've had orthopedic hardware in there and they were well-functioning previously and now they're not, you ought to think about infection on your differential diagnosis. Red, hot, and swollen. That's kind of your typical workup for infection. But keep in mind, a lot of ER physicians, maybe some of them are on the call here too, see immediate post-ops of ours with hips and knees. And guess what? They are red, they are hot, and they are often swollen. And so infection may come to mind, but these are certainly difficult to differentiate from the acute post-operative joint replacement. And so we've had not one or two, but many patients started incorrectly on antibiotics, something I'm going to get to in the future here, when they just had a post-operative course. So redness and swelling, it has to be taken with a grain of salt. Worsening joint range of motion is a good one. This kind of goes hand in hand with progressively worsening function. When you have a previous range of motion that was good in a knee or a hip, and now you don't, you really ought to think about infection. But this doesn't mean that they don't have an infection just because their range of motion is good. I see the residents say all the time, no pain with micromotion. Well, just because they don't have pain with motion, first of all, I don't know what micromotion is, but no pain with motion, that doesn't mean that they don't have an infection. You have to think outside the box and say, is this patient a good host? And what else is going on with their immune system? And then positive or plus or minus systemic symptoms. This could be fevers, chills. It depends on, as Dr. Hockman pointed out, the virulence of the organism. And some of these are slow, insidious organisms that may not mount that massive sepsis inflammatory response and warrant fevers or chills, whereas others might. So you got to have that clinical suspicion to start with. This also comes down to looking at the patient as a whole. What are their risk factors? We always look at M&M and say, okay, well, what were their risk factors? Could have some of them been prevented or optimized? Diabetes, uncontrolled glucose control is a huge one. Smoking, obesity. Really, obesity might come down to the malnutrition rather than the weight itself. Inflammatory arthritis. This comes along with things like immunosuppressants. Have they been appropriately managed for their biologics or their disease-modifying agents? What about timing? So this is what I alluded to earlier. There's three really traditional historic classifications. And as Dr. Hockman pointed out, there could be an acute hematogenous spread, but really it's most of our infections are in the acute postoperative period. And we usually see this around 2 to 6 weeks. I think we often talk about it and it's tested, but really I don't think PJI can really be diagnosed in the first 1 to 2 weeks. I think a lot of our colleagues would agree it's really hard to differentiate from that acute postoperative phase. And although the initial inoculation may happen at that acute postoperative phase or intraoperatively, it's really hard to say somebody has an infection at 1 week after a joint replacement. So really between that 2 to 6 week period, I think that that's when we diagnose. And in a previously well-functioning joint, you got to see whether this was seeded from some other invasive procedure. Something controversial, but with dental prophylaxis going away as a guideline and colonoscopy now being talked about more and more, a little bit controversial. Chronic is anybody who's had prior history of infection in the same joint and failed prior treatment. Here are our laboratory tests. I'm not going to go through these all, but just suffice it to say ESR and CRP are your take-homes here. I think aspiration data is still very key. Right now, we're looking into our serum biomarkers and ratios of serum biomarkers sufficient instead of an aspiration. And while some research that we're doing right now shows some promise, I would tell you the answer is no. You need a local source of diagnostics. So what are the different acronyms here? So SSI is surgical site infection. The basics are any infection where surgery took place, and this could be, around an implanted material like a hip replacement, knee replacement. That counts as an SSI. But really, when you look at the terminology a little bit more globally, you have NHSN criteria, which a lot of hospital systems, infectious disease doctors, National Healthcare Safety Network definition of infection. What does this entail? This entails 2 positive specimens or a sinus tract, in addition to three of the following minor criteria. And we're going to get to some of these minor criteria, but I want to point out that the NHSN checklist comes directly, if you look at the second bullet point here, directly from the Musculoskeletal Infection Society, MSIS, criteria that were adopted in 2013. A sinus tract, just for those of you guys to know, is defined as an open passageway that extends through the soft tissues and results in dead space with potential for abscess formation. Usually not directly on the incision line, slightly away, or even sometimes we've seen sinus tracts erode through well away. Well, the NHSN focuses on acute postoperative. MSIS looks at very similar criteria, 2 positive organisms or a sinus tract, or minor criteria, ESR-CRP, a synovial white cell count, a synovial polymorphonuclear neutrophil count, or histology. And really, interestingly, with the MSIS, they categorize not just acute, but acute and chronic. So chronic greater than 92 days, acute less than 90 days. And you look at the breakdown in joint aspiration, it's much lower as expected for that chronic, insidious versus the acute, very virulent organism that's going to mount that 10,000 white cell, 90% neutrophils. So a couple things I'm going to go through quickly here. Leukocyte esterase, something we're looking into again. It's been looked at for 10 plus years, including at Rothman. Very cheap. We look at the AAOS practice guidelines, and it's very much an algorithmic approach. This was from 2013. It looks like you start with one end of the spectrum, you work your way up to infection on the other. So 1, 2, 3, algorithmic, yes or no type approach we used to see in guidelines. Well, let's fast forward to 2018. This is what we're using for the most part now. It's called the International Consensus Meeting, a group of ID docs and orthopedic surgeons. We've standardized the workflow, but this is more of what we call a shotgun approach. You kind of get all of these tests done in the office or outpatient at some point or in the hospital. You try to get as many of them done and see what sticks. Now, I'm going to posit to you that this may not be a cost-effective way of doing things. Alpha defensins and antimicrobial peptide, it can cost $760 per test. So going through really quickly in a minute, our study that we did that was presented at ACUS, the Hip and Knee Society last year, we basically looked at the cost effectiveness of using alpha defensin or not. And what we did was look at the ability to diagnose PJI without these tests and determine what proportion are inconclusive without these advanced tests like alpha defensin. And then we looked at how much cost did we save. So we had 300 plus patients that we enrolled, hips and knees, that were going for suspected infection. And if you look at it, we had nearly 100% of cases that could be categorized without using alpha defensin or synovial CRP. So when you look at it, only 3.6% of the cases were considered inconclusive using our preoperative and intraoperative data. That's simple cultures, ESR-CRP, synovial white blood cell count, and PMN. So the financial burden of this, if you look at it, we looked at our cost savings. It could be up to $29,000 to $140,000. This comes down to the fact that ESR and CRP are really cheap, $10 of each, and a white aspirate analysis is $62. So really, really cheap. So in general, this has been repeated again and again. I would posit to you that the routine use of some of these advanced diagnostics is not necessary. We're really using them in equivocal cases. And our future is turning towards rapid value tests where you definitively diagnose infection in hours and you can actually get the organism. So this is next-gen sequencing or molecular-based PCR, which we're using at NYU routinely. And I'll tell you that, looking at next-gen sequencing, for PCR, it's selected organisms. Next-gen sequencing, it includes all organisms. The concern is false positives, but here's a case example. We got the data back from last year. Our turnaround time was less than 24 hours for these tests, whereas for positive cultures was 3 days. So I'm going to conclude by saying, in a case study, clinical suspicion is key. ESR and CRP are very, very important. But joint aspiration really adds a lot of value. And I do this for all my knees at the same time. For hips, I'll send them usually to our MSK radiologist and get an MRI before the aspiration if they request it. I'll send for a cell count, crystals, and culture. And then I'll add a BioFire PCR if I really have a high suspicion or if it's unclear. So in conclusion, some do's and don'ts. Always take intra-op cultures. If you're worried, aspirate it. And please don't give antibiotics in the ER unless you really have identified an organism from your culture. This was a case that we treated with a 1-stage. And, we were very happy that the BioFire came back positive for strep PCR when everything else was negative, but the diagnosis was clearly pointing towards infection. So we did a 1-stage, which actually Mort and Armin are going to talk to you about now. So diagnosis, clinical suspicion. It really will help you with your treatment down the line. Thank you, guys, and happy to take any questions at the Q&A panel in a couple minutes. Mort, we're going to turn it over to you and talk about effective surgical debridement tools and techniques here now. And we're excited to see some of the tools and videos you have going here.
Excellent. Thank you, Vinay, for putting this wonderful webinar and great group of people together. I appreciate it. So I'm going to talk a little bit about how do we do a good surgical debridement and what are the tools and techniques that we have. These are my disclosures, but they're not relevant to this talk. So as we heard, this is a multidisciplinary collaboration effort. Neither one of us can treat infection in our patient independently. So in terms of surgeons, we know that thorough debridement, local control, and managing the implant, either 1-stage, 2-stage, or 1.5, that we'll talk about it, is essential. Now we have our infectious disease colleagues who can guide us on local and systemic antibiotic therapy for dose and durations. The plastic surgery team, which will cover a lot of the managing of closure, prior incisions, soft tissue coverage, and very, very complicated cases that it's outside of our scope as orthopedic surgeons to deal with. And of course, the patient. We should not forget that patient has quite a few host factors that we can optimize in terms of, higher risk for infections and also compliance, which is very important. Education of the patient is essential to get a good response. So as we heard from Dr. Hockman, biofilm is what we are really, really trying to avoid or treat. It's a very complex communities of microorganisms that have these very extravaganza of extracellular matrix, and it provides them or shields them from host immune system, and all the antibiotics, they adhere strongly to the implants, and sometimes it necessitates removal of an entire implant to eradicate them. When the biofilm forms, it's very, very difficult to detach it from the implant. It starts with adhesion to the implant surface, especially metal, but plastic or any other foreign objects are not immune to biofilm. And then it starts to proliferate and maturate the entire protective biofilm tissue. And it is this biofilm that results in recalcitrant treatment of PJI, and we have to remove some of the implants. So going through some of the principles of debridement and local control, the first thing is adequate exposure. So if we don't have adequate exposure, of course, we can't do a thorough debridement. We don't have enough room to remove the implants and do a good surgical treatment of the local control. And then we have to try to see if the implant needs to come out. In chronic cases or acute cases that the implants are not osseointegrated, especially in hips, we might have the opportunity to remove the implants. But in general, if the implant needs to be removed, you have to be very cautious about removing them safely, preserve bone as much as we can. And then we have the plethora of washout that Dr. Arshi is going to go through, and some of the local antibiotics that we can use intraoperatively for additional local control. In total knees, some of the things that we all think about as orthopedic surgeon is the prior incision. Sometimes these complex infection cases have more than one incision, or they have prior hardware and prior fixation. So use of appropriate skin incision is essential. And a lot of times I do consult with our plastic surgery team, especially if we want to use local flaps or some sort of coverage, it's great to have their feedback initially. We want to protect the sensor mechanism, and total knee is, of course, an adequate exposure to eradicate the scar and do a thorough synovectomy and mobilize the quadriceps. And we have to be very cautious of respecting collaterals and capsule and avoid any excessive bone loss. There are variety of different techniques that can help us gain more exposure, from pie crusting to quadriceps snip to VY or tibial typical osteotomy, which are at this point very rarely performed, but in severe cases, it's good to have those techniques in your toolbox. Some of the principles of exposure for revision total hip is approach. Most of the times it's done through posterior because we are all more familiar with that technique. But as long as you do it through lateral or anterior, and you have a good exposure and you have good expertise, the approach really does not matter. As long as you have the adequate exposure and can remove the capsule and the pseudocapsule and on the scar. And then we have a lot of tools in terms of removal of cup and removal of stem. You can try to remove the stem from the top. If it's well fixed, you need to do an extended tibial osteotomy. Some of the principle for removal of the implants is that these are critical steps. You have to know the implants. There are specific types of instruments that can be used to remove specific implants. Sometimes you have broken hardware, or you have to be prepared for broken hardware. It requires a thinking ahead of time to make sure you have all the implants and sets available, and you have a systemic approach to removal of the implants. Surgical debridements, I can't overemphasize it. This is very, very important for local infection control, removing all the necrotic tissues, purulent materials, or any foreign bodies, and biofilm if you can. There are devices that will go over that in terms of removing biofilm. Synovectomy is very important because synovial membrane is often colonized heavily by bacteria, and it's crucial to remove the synovium as much as you can. If it's acute, as we heard from Dr. Agarwal, we can do a debridement, antibiotics, and implant rotation, or DARE, which has a high success rate in terms of acute infection, but it goes back to the basic of making sure you have adequate exposure, adequate soft tissue removal for infected cases, and synovial membrane. And of course, it all depends on what the bacteria is, right? Some of the resistant bacteria may have a less chance of survivorship with the implant retention and antibiotics. So in terms of debridement, as I mentioned, thorough debridement is key. There are ultrasound devices that helps remove biofilm. And after you remove all of these debridement and the necrotic and infected tissue, then you proceed with either irrigation, washout. There are multiple different products that can help us with the washout, and then you proceed with either you put antibiotic beads, or you have some form of a spacer that acts as a temporary joint. Methylene blue has been very interesting in terms of finding the adequate tissues and affected material or synovial membrane that you need to debride. So the way it works is that you just have methylene blue ready. You inject into the joint prior to exposure, and the dye stains the affected tissue surrounding the implant, and it makes it very easy to see the tissue and do a thorough debridement. In terms of debridements, we have the open debridement, which I think it's the standard of care at this point. Arthroscopic debridement is mainly reserved for patients that don't qualify for an open debridement for a variety of reasons. They might be in septic, or they're not cleared for an open debridement. So arthroscopic debridement is, of course, more minimally invasive, but it does not really address removing the entire tissues that are infected, or some of the modular components that we can address by removing or replacing during open debridement. The ultrasonic debridements have been around for a while, and the way it works is that the ultrasound provides a stream of water jet that removes a very precise layer of tissue and even biofilm. I've been using this for the past 7-8 years, and I think it does add quite a bit of value in terms of removing biofilms in the single stage surgeries, or even washout in areas that it's hard to reach or do thorough debridement. There are a variety of antibiotic beads. Most of the time when we use them, they are dissolvable. They have less systemic antibiotic side effects, and they release these antibiotics over an extended period of time, but some of them may increase wound drainage. That I think Dr. Arshi will talk a little bit more. So in terms of types of revision, we have one-stage revision, which is mainly done in cases that we know the virulent in advance and they're not very resistant. It includes removing the infected type of implant and doing a very thorough debridement, and then you immediately insert new prostheses with different type of protocols. So most of the time, we scrub, we remove everything, and then we re-prep and drape and use new instruments when we are reinserting the prosthesis. Of course, it's less morbidity, and it has less infection recurrence than DARE, but selection criteria of the patient and strict surgical protocols are important for the success of this procedure. The two-stage is kind of the gold standard. Currently, success rate depends on the organism, but it's as 70s to 90s. Most of the time with the thorough debridement and non-invasive bacteria, it's a very high chance, but involves removal of implant and then putting an antibiotic spacer and then subsequent reimplantation when the infection is eradicated. Now, in terms of spacers, you can have a static spacer, which is good when you have a very large space and you want to maintain length. But of course, it has less motion and may lead to higher bone loss. The articulating spacers provide better functioning intermediate aspect of the joint and allows range of motion, and but they have similar short-term reinfection rates compared to statics. These are some of the images of a articulating spacer with intramedullary dowels and beads. The 1.5 stage revision is kind of in the middle between first stage and one stage and two stage. It provides a more permanent antibiotic spacer in case you decide not to go back and you have a bacteria that is not resistant. So it does offer a well-functioning articulating spacer, and hopefully you can avoid a second procedure. I'll go over some of the tools very quickly. There are a lot of tools in terms of implant removal, from high-speed burrs to osteotomes. They come in a variety of shapes and different sizes that help surgeons do a thorough debridement or removal of the implants. There's some specific type of instruments that are used for particular implants, especially for hips. We have different saws or separate cutting saws or jiggly saws that we can use. And the idea is that you use these tools to get between the implant and cement interface and hopefully preserve the bone as much as you can. There are a lot of different rigid or flexible osteotomes that are available, and we all have to make sure that during these surgical procedures we have all of these available for doing a very thorough removal of the implant without damaging bone. There are different types of instruments. I'm just going to go through them very quickly because we're running out of time. But knowing different types of removal tools at your disposal is essential because it can make your day much easier and less stressful removing the implants. The new cup removal tools have been very good in terms of trying to preserve bone in acetabulum. Basically, they go between they come in different sizes, and you can use them to break the bone implant interface and have more preserving bone methods. There are different cup removal tools that we're using at NYU that are powered. It makes them easy. This is an example of a stem removal tool that's specific to that type of implant and makes removal of the stem quite easier. And of course, there are different types of universal tools and trough lines that we need to be prepared for. And the other things that I will touch on before closing is the cement removal tools. There are ultrasound instruments that heat up the cement and help you remove the cement from the top, or you do an osteotomy. And lastly, having a diamond tipper if you decide to remove or cut the implant is important to have in your momentarium. This is just a quick video of doing an osteotomy. Removing of well-fixed stem. These are very challenging cases. Thank you so much.
All right, thanks for a lot to unpack with taking out our implants. Obviously, super interesting to orthopedic surgeons. So apologies if it was, a lot of metal and gore for the non-surgeons on there. This is what we do day in, day out, taking out as revision surgeons, well-fixed implants, and teaching our fellows how to do that, in an expedited fashion. So hard to cover all that, but definitely some good tools and some good, products that maybe some of our audience members might have further questions for you on later on. With that, Dr. Armin Arshi is going to come up here and present with my title that I gave him, Throwing in the Kitchen Sink. So, these are bad infections, bad actors. Maybe at some point we just need to throw in all of our tools and armamentarium into the local area, and Armin's going to tell you what he does.
Right. Thanks, Vinay, for putting this on together, and hopefully this will continue to be helpful for you guys. My talk is on throwing in the kitchen sink for managing PJI. I will be talking about a few different modalities. These are my disclosures, none of which are relevant to this talk. So why do I throw in the kitchen sink, figuratively, for managing PJI? The fact of it is, and as you'll see throughout this talk, that there's no clear evidence for what is the best practice in managing PJI with regards to specific modalities for local treatment. And so for that reason, I try to give everything possible. The success rates for PJI have unfortunately remained relatively static, about 50 to 80% for DARE, 80 to 90% or more for two-stage exchange. But the fact is that these surgeries carry a high morbidity and mortality, and the outcomes tend to be dismal for people with reinfection. And so we want to do our best to make this happen right the first time. So the different kitchen sink that we're going to be talking about today are irrigation solutions, antibiotic beads, and antibiotic cement. So starting with irrigation solutions, so what options are available? There's a wide variety of different things that are used at our institution throughout the United States. Dilute povidone iodine, CHG or chlorhexidine, hydrogen peroxide, acetic acid in various forms, and Dakin solutions are just some examples. And they come broadly in two different categories of antiseptics and surfactants. Antiseptics, of course, have antimicrobial properties, whereas surfactants may have more targeted effect on managing biofilms. And they come in a wide variety of different concentrations and different commercial mixtures that are available to you and available for various costs. So the big question is, how much of this should I use and what should I use? So in the last international consensus meeting, no specific irrigant was recommended in totality, but the overall recommendation is that a minimum of 6 to 9 liters are recommended for use in PJI cases, whether for DARE or PJI. Going through each of these individually, there's evidence supporting each one of them, mostly based off in vitro data, though clinically there is some better data on povidone iodine. So this is a cell membrane oxidizer that has relatively low cytotoxicity at low concentrations. It's available at various different formulations. So the 10% is the non-sterile that's available in your prep kits for skin prep, whereas 0.5% is something that's been recently made available in a pre-sterilized surgical dispenser. And fortunately, no cases of bacterial resistance have been reported with PBPI. Again, a strong consensus has been made for recommending its use in surgical site infection and arthroplasty based off the last ICM meeting. We expect the same this year. It also does have some benefit for biofilm disruption. There's good evidence that 3 minutes of contact time are the minimum needed to have a sufficient antimicrobial effects. CHG is another common option available. So Aricept is the solution that we have available, commercially available at a 0.05%. This again does cause biofilm disruption as well, and there's some evidence that there may be some antibiotic resistance and cytotoxicity to it. So we're typically not using this individually in practice, and NYU, even for primary cases, has transitioned to the use of Surgiphor. Another commonly used irrigant is hydrogen peroxide. So this has hydroxyl free radicals that are made and allows it to denature cells and disrupt biofilm. It can also do mechanical debridement via effervescence, which you'll see with the lots of bubbles that are generated when using this intraoperatively. As a result, rare cases have been reported of air embolism, so it's important to irrigate this very promptly thereafter, and I always do in my cases I'll go over. And there's some evidence showing that combined with iodine, both clinically and in vitro, that this can have a synergistic effect and is one of the more well-recognized combinations. Dakin solution is one that's commonly used by our plastic surgery colleagues, not necessarily intraoperatively, but for wound management post-op. It is a potent oxidizer and cell membrane disruptor, and it helps dissolve and debride necrotic tissue. It can form a toxic precipitate, and it is not currently sterilely packaged, so there's some debate as to whether this is used intraoperatively. Again, because it's not sterilely packaged, you would be using this technically off-label, but it does show in vitro data that this does show the highest percentage reduction in biofilm formation when compared to any other formulation, including betadine, peroxide, and others that I mentioned. The other main category of debridement materials are surfactants. Again, these act as ionic emulsifiers that help to remove bacteria and biofilm very directly. They have a lot of different active ingredients such as benzalkonium chloride, BHC, and PHMB. They come in mixed solutions with a wide variety of different components, including acetic acid. Unfortunately, they do come at a significant cost, about 5 to 10 times what is available for other commonly used irrigants. So not routinely used at our institution. A word of caution, playing chemist can lead to questionable results. This is a study published from Stanford looking at the different precipitates that can be formed. And as you can see, just having these different irrigants in presence of one another can lead to toxic byproducts. And so for that reason, the authors, and I would recommend to you as well, to dilute as much as possible to get these toxic byproducts out of there. What does the evidence say in conclusion? Well, in vitro evidence is generally mixed regarding the best antimicrobial and cytotoxicity properties. There's some inkling towards povidone iodine, as I mentioned, but in general, it appears that an antiseptic solutions used in combination have the best results. But unfortunately, there's essentially no clinical data supporting these. So this is my personal kitchen sink. I do this for all my PGI cases. In serial irrigation solutions, I start with Aricept, dilute with normal saline, then I go to Dakin's, normal saline. I do a dilute combination of 70% alcohol, and then I do another combination of hydrogen peroxide before finishing the Surgiphor, each time interrupting with 1.5 liters, and the entire OR is very unhappy because they're opening so many different suction tubings and getting more irrigant for me constantly. So the second tool that I posit to you is very useful is antibiotic beads. So historically, antibiotic beads were in the form of PMMA, which is the same material used to make cement. It was used as a void filler for open fractures. Unfortunately, the release profile of these was not as favorable. As I'll show you later, antibiotics eluted almost completely within the first few days, and there was no long-term sustained sustenance of antibiotic concentration. So people have since transitioned to calcium sulfate beads, which dissolve and elute antibiotics over several weeks, a total of about 6 weeks. And they typically exceed minimal inhibitory concentration for several weeks and typically require heat-stable antibiotics because the exothermic reaction required to generate them. So this is one such antibiotic bead concoction. This is the Stimulan beads, but there's a wide variety of bead formulations available. Literature shows that they exceed local concentrations. The concentrations exceed MIC for a period of up to 6 weeks postoperatively using some of the most common antibiotics used, including gentamicin and tobramycin. And this is a useful adjuvant that has been well described for usage in DARE, single stage, and two-stage exchange. So I would recommend you consider using them in a wide variety of settings. The on-label use technically describes the use of 3 antibiotics, vancomycin, which gives you gram-positive, including MRSA coverage, and then gentamicin and tobramycin, which are 2 different aminoglycosides and may act synergistically when used in combination with vanc. The typical recommended doses that are used and what I use is 0.5 grams per 10 cc's for vancomycin and 0.3 for each 10 cc bag of stimulant for aminoglycosides. And again, higher doses are possible, but they may compromise the known mechanical and elution properties, though they've been well reported in the literature. It's not just the on-label uses. Various authors have reported a wide variety of different antibiotics they've used based off of targeted therapies. This is a summary of literature previously shown by my colleague Ed McPherson at UCLA, who described antibiotic-eluting beads and described their mechanical properties for a wide variety of these different options. So if you have any doubts, I recommend you hit the literature and look at what exact organism you might be trying to target, though with most cases, you'll have good coverage with vanc and aminoglycoside, which is on-label usage. So the reason that this works for a wide variety of different antibiotics is that the calcium sulfate elution properties are very well predictable. This is a study published in 2009 describing daptomycin, which can be used for vancomycin-resistant organisms, and showing that, again, elution can be sustained about MIC for a period of 4 to 6 weeks. What are some of the complications that you might run into when using beads? Persistent wound drainage is frequently mentioned, and it can persist for several weeks. Anyone who's managed this will have the jitters in the office when you keep changing wound vacs or seeing patients in the office with drainage, and rates are reported as high as 50%. It is correlated to the volume of beads used, and rarely was it seen in this particular published series from my colleague McPherson, who described it as being non-existent when used for 20 cc's of beads or less. And again, you can also get rare other complications such as transient hypercalcemia or HO formation. Transient hypercalcemia can happen in up to maybe 5% of patients. It is very rarely symptomatic, though I have seen cases with high doses of beads where patients can go into renal failure or require prolonged intensive care as a result. So my kitchen sink, sort of what I use for most cases for hip and knee PGIs, I'm almost always using 20 cc's of stimulant deep to the fascia. For knee PGIs, where I'm doing a 2-stage exchange, I will do an additional 10 cc's into the femoral and tibial canals. Again, not literature proven, as you'll find limited literature on this, but my personal recommendation for eradication. The concentration I use is 0.5 of vanc and 0.3 of toba per 10 cc bag. And I will add in antifungal coverage with either voriconazole or amphotericin B for fungal PGIs, or daptomycin for cases where there's a documented vancomycin-resistant organism. To prevent drainage, I use a wound vac in all cases, as with all my revisions, and I will use a superficial drain in the case of hips. For knees, I will immobilize them for 10 days to try to mitigate the risk of wound problems from drainage. Last of the 3 is going through antibiotic cement. So again, antibiotic-loaded bone cement has been well established and is considered standard of care in the treatment of hip and knee PGI. This allows for you to have mechanical support while also allowing short-term local delivery. While it's debated for use in primary and aseptic revision cases, it is considered standard for PGI cases. So as we all know, antibiotic-loaded bone cement is available in a wide variety of different commercial formulations. A couple of the common ones used at NYU, Simplex and Palicos, are shown here. These typically include low-dose antibiotics, which is defined as less than 1 gram per 40 grams of cement. That's because this will not compromise your biomechanical properties. But in PGI cases, most of us are doing custom-made antibiotic-loaded bone cement, allowing us to have higher doses. So high dose is defined as greater than 3.6 grams per 40-gram bag. And this allows you to personally customize what antibiotics you're using, what dose you're using, and what the mechanical properties and set time there are. And this is also at significantly lower cost than if these were commercially prepared. A word on cement viscosity. So as we're well aware, there's a wide variety of different commercial viscosities available. In general, as your viscosity increases and becomes more thick, You have a shorter set phase, but you have a longer working time for molding. There's no evidence in the literature that viscosity affects either the elution properties or the mechanical survivorship of cement. And so it's ultimately up to you as to what you use. At NYU, we have the three different viscosities are all well represented. Simplex, made by Stryker in both P formulation, HV are available for low and high viscosity, and Palicos is your medium viscosity cement. In terms of antibiotic options, we again discussed previously with regards to beads, but you need to use heat-stable antibiotics as there's an exothermic reaction used in the generation of cement or beads. And the most commonly used are vancomycin and your aminoglycosides, either TOBA or Gent. But a wide variety of different formulations have been described and used, and I would encourage you to look at the literature if you're considering any specific dosing for use. In general, as we discussed, this does not allow for long-term elution. The elution rate is very rapid for PMMA bone cement and peaks out at around 24 to 48 hours. So if you want extended antibiotic coverage, I recommend the use of beads supplementarily. So how can you get more antibiotics to elute from your cement? Well, you can use more antibiotics in there to begin with, or you can use something that has higher cement porosity. So hand mixing does not completely elute all bubbles out. And so either doing the hand mixing or adding additional liquid phase will give you more porosity in cement and may potentially lead to more antibiotic elution, though clinically this hasn't been shown. As we're well aware from multiple different sources of literature, there's no compromise on the strength of your cement when you use up to 2 grams of cement per bag, 2 grams of antibiotics per cement bag, but the mechanical property decline is dose dependent thereafter, as shown in multiple different studies, including here, where high dose antibiotics significantly reduce the mechanical strength and long-term viability of cement. How much antibiotic should you be using? So again, 3.6 grams is what is defined as high concentration. And generally speaking, as you increase the concentration, your mechanical strength will decrease. Arlen Hansen and colleagues described in 2005 JBJS their typical dosing, which they recommended of 3 to 6 grams of vancomycin and 2.4 to 4.8 grams of an aminoglycoside per 40-gram bag that they use. Though Brian Springer from OrthoCarolina has reported higher doses up to 10 and 12.5 grams total of antibiotics without significant compromise. Some technical tips for me. So in general, if you want to maintain doughiness of cement when adding high dose of antibiotics, I would recommend either using an additional dose of monomer in a 2-to-1 ratio or adding saline to maintain its consistency for molding. I would mix the cement prior to adding antibiotics. I find that this makes a big difference in terms of the consistency. I use a 2 mm syringe to fill articular defects prior to application of the spacer. I don't pressurize, but I do fill articular defects, particularly on the knee. And again, I always recommend review the literature before each PGI case if you're not going to be using your standard vanc aminoglycoside to look at what options are available. As a warning, nephrotoxicity certainly is possible and something to be aware of and discuss with your ID colleagues. In this study, they described a higher rate of postoperative AKIs in patients who had high-dose antibiotic spacers placed or had chronic kidney disease, so be wary of that. So my kitchen sink is summarized as followed. So I typically use low viscosity. This is just my personal preference. I mix 3 grams of vancomycin and 2.4 of TOBA per bag. And I use 10 drops of methylene blue to maintain the blue coloring so I can tell exactly what is antibiotic cement for later removal at my second stage, or should I ever have to come back. I typically prefer to use vacuum mixing for more consistent concentration of antibiotics, though it's your choice as to whether you want to do that or not. I add additional monomer, and in cases of multi-drug resistant organisms or culture negative species, I might consider adding additional antimicrobials like I posited to you earlier. For my knee spacers, I prefer an articulating spacer, and I use a CR femur with an all-poly tibia. I use 2 bags of cement. For my hip spacers, my typical preference is to use a constrained Biomet Freedom liner with 1 to 2 bags, depending on the size of the void, possibly adding screws in cases where I worry about instability, and then a Dupuy Prostalac spacer, which has been well described in the literature for helping maintain motility and function. Again, number one priority always is debridement, as Dr. Mefta mentioned. You want to make sure to have a clean base before you move on and start putting in hardware. Thanks.
Amazing job. That was fantastic, Armin. Really just covered everything from 1, 2, 3 with your kitchen sink. I knew there was a reason I asked you to do this talk. I think you had every basis covered here, and really it's a testament to kind of your knowledge on this and expertise. So thank you for sharing that with our audience. Now, Pierre, before we get to you, I think we do have a little bit of a time for a question and answer here. I think our next session is going to start around 7:45. So with that, we had a couple of questions here in the chat, but I want to encourage everybody to ask questions in the chat. I will cover as many of them as come in as possible. So feel free to send those in, and they should come into my direct queue here. But I'm going to start with Sarah. You mentioned Canada, so very difficult to treat. I actually wasn't aware that it also could form potential clustering and biofilm formation. How often are you seeing Canada, not respond to traditional antifungals, whether that's IV or oral, and what are we saying as the virulence mechanism? Is it usually fungal plus another organism because it's so opportunistic?
So in the handful of cases I've seen of Candida PJIs, I probably half of them have been with another organism.
Yeah.
All have been in patients with a history of PJI in that affected joint. So they've usually had at least 2 prior revisions in that joint. They've had a lot of antibiotic exposure. It's not something you see in like a normal person who has, not had a bunch of surgery.
Right. I would agree with you. It's usually, like you said, a second time around, third time around, and it comes up with some other organism. You see the culture results. We're not routinely sending for fungal cultures on first-time infections or anything like that, but it does show up. I think, correct me if I'm wrong, it will show up on a standard culture if you give it long enough.
Candida will grow just as readily as most bacteria in a standard culture. The fungal cultures would really be for, something more esoteric, like you're worried about aspergillus or, an endemic fungi or mold that you would really need a fungal culture for. You don't need a fungal culture for Candida.
Yeah, I think it's a great point. I wanted to clarify that misconception because, I'm sure Armin and Mort agree, like you will get fungal growing out, even if you say, wait a minute, I didn't send for fungal. Well, guess what? You sent for aerobic, anaerobic, it's going to grow on there. And if you incubate long enough, it will show itself. So I have had several cases where that's been the case. But I do send fungal for my really strange kind of stories. Either it's a patient that's had 6 or 7 surgeries prior, outside countries. I'll send a specific fungal panel for my cultures to try to pick something weird up. We all ask this, what do you feel like is the worst actor now? MRSA is kind of the notorious one out there, but what's your experience?
So for me, I feel like Staph aureus in general, whether it's methicillin resistant or not, is the most difficult for so many reasons. One, it can be so pathogenic and it can make people very sick very quickly. Often when I see TJIs with Staph aureus, these patients, they wake up with an acutely hot, swollen joint, fever. It's, very overwhelming and very sudden. So, that virulence aspect of it is tricky and really requires acting quickly. And then it also requires sometimes the ID doctor saying to the non-ID healthcare providers, just be patient, let the antibiotics work, because it doesn't get better as quickly as people expect it to, in part because of such a robust inflammatory response. And then the other reason why I really respect is maybe not the right word, but I have a healthy, I treat it aggressively, is because of its persistence and its biofilm formation and how it can come back after treatment, even after debridement and, giving 6 or 8 weeks of intravenous antibiotics and then sometimes oral antibiotics. It's more likely to recur than almost any other organism I've come across for PJI.
Got it. Yeah, we talk about gram negatives and enterococcus, but I think you're right. Staph aureus has a special place, and I like how you said non-ID healthcare providers. I'm going to assume that that means the orthopedic surgeon that wants answers tomorrow and change. That's kind of how we're wired. Let me ask a question to Mort. You talk about all these different implant removal techniques. Really, does all the hardware have to come out? Like, are we in an era that we have to use all these instruments and really go after every piece of metal? I know that Vin and Sarah want us to say yes, but what's your opinion?
I think so. So it goes back to biofilm, and biofilm forms not only on metal but also on plastic or any foreign material, or even screws. So if I am more inclined to take implants out if I'm even between the borderline of acute versus chronic, because if you leave the biofilm, then your future success goes down dramatically. And I think the best surgery is the thorough debridement of the local control on the first time you do the case, because some of these very difficult hosts that are very prone to infection for a variety of reasons, especially low immune system, multiple surgeries lead them to more resistant bacteria, and then they get contaminated with Candida, like Sarah was talking about, and then that's just beginning of the end. It's very difficult to eradicate that. So, I have tendency to remove things. If I'm there and I'm removing the cup, the screw has to come up with it. The stem, same for total knees. If one implant if coming out, I think the all has to come out.
Yeah, I would tend to agree with you. I think we're changing a little bit. I think that the take-home message is get it right the first time, right? So you want to try to do as good of a debridement and take out the implants the first time and really do a thorough debridement, as both you and Armin mentioned, so that your chance of success in that case is truly 95 to 98%. Rather than doing, a half job or not knowing what you're doing. I think that's been shown is referral after an initial surgery or debridement, referral to a tertiary center. The success rates are way lower than if you just sent it to the tertiary referral center the first time to get it done. And then you don't end up down that slippery slope of now I got to take out well-fixed cones from a third time revision that are down, in the tibia or, up in the femur, a well-fixed cemented implant that's all the way halfway down. And we're really sacrificing function for infection eradication because those come hand in hand. And I'm going to ask Vin a lot of those questions when we get there. So Armin, I'm going to end with you before we get to Pierre. Question for you. Yeah, you showed kind of the kitchen sink and things. Number one, are you seeing a lot of drainage with your beads? I know you mentioned negative pressure and that it could be hard for somebody to stomach that drainage. That's one of the reasons I've moved away from them, or I use them only in the deep layer or in the canal rather. But are you seeing a lot of drainage with those beads and is negative pressure the answer? And then the second question I have for you is talk a little bit about systemic effects in your experience. You mentioned nephrotoxicity or calcium hypercalcemia. Any patient experience with those?
My patient experience with those comes during actually my training. I use low doses of beads. I mentioned no more than 20 cc's, and I think that's really been at a point where I'm not seeing significant nephrotoxicity or transient hypercalcemia. I did see cases with massive bead doses, 40 to 50 cc's used in a patient, where you would see this happen more commonly. And so for that reason, I've chosen a lower dose concentration. With regards to, remind me your first question again exactly. Sorry, I have you on. You're on mute. Sorry.
Oh, sorry. Do you have experience with drainage with calcium sulfate? Is it negative pressure kind of taking care of that, or have you seen that?
So in knees, I think immobilizing them has really made a difference, and I don't see it happen very often. With hips, because immobilization is not really feasible or possible with an articulating spacer, I've still seen drainage. I always use it deep to the fascia, just like you mentioned. I started using superficial drains to try to offload that stuff coming from the skin as well. The drainage just sort of peak at around the 7 to 10 day point, and then sort of abates by three weeks. And it's sort of this cloudy looking drainage. It's been benign. It hasn't led to any secondary infections from what I've seen, but it certainly is something that I'm keeping a close eye on. and changing Provenus frequently in the office for.
Got it. A couple really good questions here. I'm just going to answer a couple of them myself. Antibiotic prophylaxis for joint replacement with teeth cleaning versus more extensive dental work. Well, here's a very controversial open a can of worms here. I'm not going to open the can of worms, but basically the ADA guidelines and the ACUS guidelines are that routine dental work that includes cleaning, non-implant related things, does not require any antibiotic prophylaxis. Now, that being said, do a large majority of my colleagues still prescribe prophylaxis? I don't know if that's to stop the Epic My Chart messages or if they truly believe in it, but yes, a lot of people are still prescribing it. I personally don't. Again, not data proven, but I tell them if they're getting an implant in their teeth, then take the antibiotic prophylaxis. Otherwise, I don't know that we have enough evidence to support routine prophylaxis, so not for dental cleaning. Experience with vancomycin powder. We're going to present at the Hip and Knee Society again our experience with vancomycin powder. We did a randomized control trial sponsored through ACUS. Didn't really find a huge support for using vancomycin powder in a randomized multi-center trial around the country. That being said, I think it's a low risk, potentially high reward strategy as long as you're not using too much of it. I stopped using in my superficial layer because of my concerns for, again, wound healing. And then somebody had a question about allergic reaction to the metal versus osteomyelitis. Similar presentations, yes or no? Just to, raise of hands between, I guess the three orthopedic surgeons here, Mort, Armin, myself, how many metal allergy tests are you guys sending patients for workup? You can do 0. Mort, 1. Okay, so we're basically, we're not a cult, but we're non-believers in metal allergy potentially. So there is a role of it, but we don't go out of our way, is what I should say, to go send the patient for allergy testing. Usually, if they present like that, we're working up for infection. So I think that, I know some people will disagree with that, so I'm just going to leave that out there. I do want to get to Dr. Sade, Pierre Sade's coming to us from the plastic surgery world. Hopefully we have some plastic surgeons on the call to see his fabulous work and some options for people that get called to save the day. When we call you guys in, Pierre, when I call you, you're probably like, oh, this guy's texting me again. Great. Another failed knee replacement that needs to cover. Well, we're gonna ask you to tell us what you have to offer.
All right. Well, thank you. Is this release for me to control? Yeah. There we go. All right, thank you, Renee. So then thank you for the opportunity to speak this evening. So I'm going to cut to the chase. So when to call the plastic surgery? Well, so post-operatively, I think early in the setting of infection or suspected infection. Honestly, I see lots of just skin issues and suture issues, and obviously the concern is always, is this extending deeper down? And I'm happy to get involved. And honestly, if it's just a skin problem, it's my problem. So we usually take care of that in the office. Once in a while, we'll do a little debridement in the OR with obviously a heads up with orthopedics. And then obviously, if it's deeper, we should we need to get involved, I think, early on, because these can often be multi-stage procedures, both in terms of hardware removal, an intermediate stage, and then hardware replacement. So it's good to be there to help with all of that, to handle the soft tissues, and also to incision plan, because we can burn bridges if the wrong incisions are made and compromise what we need to do to achieve closure. And then preoperatively, again, incision planning can be very important, but particularly if there are lots of prior trauma or incisions to the area of surgery, if there are prior flaps to that area, if there's unstable soft tissue because of lots of prior surgery or radiation therapy, and in the setting like severe obesity and diabetes. And these are just examples of patients sent to me for incision planning, and I appreciate it. And these were all sort of effectively dealt with preoperatively. And as a general principle, never be afraid. If you have any other option, just use old scars. You're not going to create any new problems with old scars. And if you have to adjust an access incision using an old scar, just incorporate it. and you usually will stay out of trouble. Don't undermine skin grafts because skin grafts do not get blood supply from the surrounding skin. It's all from the underneath soft tissue. So if you undermine a skin graft, you're going to turn it back into a skin graft and scar that it is, and likely lose it. Prior flaps, well, most flaps, especially muscle flaps, are partially buried. So if you encounter one, don't cut directly through the skin and through the flap. Cut through the skin, identify the flap. It will have atrophied for sure, but elevate the skin, dissect the skin to the edge of the flap, then raise the flap up in sort of reverse order of inset to keep it well supplied with its blood supply, and then reinset at the end of the case. Obviously, if we're involved, we will do all of that. And then if you're already dealing with a swollen patient and you're worried about postoperative swelling and difficulty with soft tissue closure, if you're using a tourniquet, just think about ischemia reperfusion. So watch ischemia time, and I would restore blood flow every 1 hour, and you'll minimize that problem. And so basically with soft tissue coverage, I mean, the question is there soft tissue loss or not? So we call it loss of domain, and usually there isn't. So as a result, usually primary closure is possible. What I like to do, and I think a lot of you folks have seen this done as well, is I like to plicate. So I don't just close the skin. I will plicate the skin flaps that are elevated on their undersurface to underlying fascia, and I'll advance those flaps as I'm doing that. So in the end, you end up with a tension-free closure at the skin level. And also, it allows for elimination of dead space, so much less space for fluid to collect to get a seroma or a hematoma. And at the end, I will range the patient. If I'm concerned about the tightness, occasionally I'll ask for a short period of immobilization, but usually not. If there is soft tissue loss, then you're probably going to be talking about a skin graft, but if it's in the region of an implant, I would say some sort of flap. So either random pattern, axial, and once in a rare while we'll do a free flap. And then everyone knows this, but obviously make sure you just deal with the two basic components in all these cases. So the capsule, the hip or knee capsule, and the skin, because you don't want a connection, you don't want fluid to accumulate and you don't want to get a chronic effusion. So just basic plastic reconstructive surgery. We always talk about the reconstructive ladder. We always want to go from the simplest appropriate solution for the problem at hand. So for your primary close, best solution. Secondary intention probably doesn't play too much a role in a lot of these patients. Vac therapy is probably useful as a bridge to closure, so stabilizes the wound, controls fluid loss, and maybe helps with some edema as well. Skin grafting, Integra, then local flaps, distant flaps. Tissue expansion really doesn't play a role in extremities, and then free flaps. So in terms of the flaps that we use, there's the well-known Matheson high classification based on its blood supply. And the good news is certainly for the hip and the knee and the shoulder as well, actually, although I don't touch upon the shoulder in this talk. Most of the flaps are type 1 flaps, so they have a single defined blood vessel. It makes them very easy to pedicle. So I'm going to talk about hip, knee, and ankle, but the hip, because there's so much redundant soft tissue, very rarely do we have to get fancy, certainly in terms of complicated flaps. So it's going to be mainly knee cases. I'll mention ankle just in terms of some of the distally based options that we have, but it'll be a small part of the talk. And also a lot of the things that I'm going to be talking about, I'm going to show cases that are not necessarily joint cases. Some of them are tumor cases or trauma cases, but the closure techniques apply. They're all in the same areas, so these closure techniques all apply to joint cases. So again, the hip has plenty ample soft tissue. If needed, random pattern flaps are great for closure, and then we have lots of axial flap options, both proximally and distally based. And this is a typical. Again, this is a soft tissue defect. This is not a joint, but again, same concept, just a big broadly based rotation advancement flap. Good option for the hip area. Usually we do a little back cut to extend the reach of that flap as needed. Very effective. In terms of axial flap options, when we're talking about skin flaps, really talking about either the ALT or a variant like a TFL flap. This is a tumor case, but obviously, if you can get an ALT to cover that, you'll be able to cover any joint problem whatsoever. So this is the ALT is based on the descending branch of the lateral femoral circumflex system. We often use it as a free flap, but in these cases, it's a great pedicle flap. And we skin graft the donor site. That was a tumor case. This is actually a joint case. And again, just from the adjacent thigh, that it provides good soft tissue coverage in the settings of just lack of adequate soft tissue coverage. The rectus femoris is another flap option, but that's purely a muscle flap. Probably needs to be skin grafted if you bring that up to the hip. But if for whatever reason the hip is not an option, in terms of bringing up soft tissue, you can bring down soft tissue from the abdomen. So a very much of a horse flap from the abdomen is the VRAM, the vertical rectus abdominis muscle, based on the inferior epigastric. It pedicles nicely down to the thigh and the hip area, and is a very robust and reliable flap. Well, when you come to the knee, well, we know it has relatively thin soft tissue. So we're definitely looking at doing flaps more often in knee cases. Again, primary closure is usually possible if there is no soft tissue loss, and we use that barb suture plication technique. Random pattern flaps, particularly bipedical flaps, great option for smaller defects. If you really have that, they need another centimeter or 2 or 3 to advance the knee flap to get them to join from a midline arthrotomy incision. Or access incision, I should say, and I'll show you that in a moment. The keystone and rotation flaps are their options, and we have a bunch of axial flaps I'll talk about. So the issue with the bipedical flap is, in these the knee access incisions are usually there already, and they've been established because you've had a knee replacement. So in the setting of having to go back in and do hardware work and then achieve closure, if for whatever reason I cannot achieve closure easily or it's too tight, honestly, just like a little counter incision allows for a bipedical flap. You have to realize that because of that central prior incision, you have quote unquote delayed that soft tissue. So it's already the skin on either side of that initial incision is hardy and will withstand the insult of another incision parallel to it. And then you can undermine that soft tissue as needed to get it over, and it buys you 1, 2, 3 centimeters, and we'll get you an easy closure without too much effort. I usually skin graft that little donor site. Sometimes I'll granulate, but usually I'll skin graft it, and then this sets you up for if in this setting or in future operations you need to do a medial gastrocnemius, you already will just extend that incision from where that skin graft is. Long-term result with that patient, similar approach with another patient. Keystone flap is basically it relies on local sort of calf laxity, and you end up doing 2 V to Ys to close kind of smaller defects. It's a little bit away from the knee, but certainly works in the knee area for smaller defects. And then you can just do a random pattern flap, just like that case I showed for the hip. This was a case where everything came together, but the distal pole, there was a soft tissue loss, and there was going to be a defect there, and obviously we want total soft tissue coverage. So I made a decision with the plan or at least the backup option of just doing a big gastroc, but it was a small defect. So we're able to just extend this incision, leave a distally based flap, and bring that soft tissue up. And the gastroc option is always there if we have any problems with this, but this worked fine, and we got good closure. In terms of axial flaps, well, this is actually an example of not very good incision planning or lack of incision planning. So this was a patient not done it in the NYU system, but there was an old medial incision from knee surgery when this guy was a child, and then he needed a knee replacement, so he had the central incision made and then joined the old incision, and then you can imagine that in that previous operation, probably that soft tissue had been elevated And so it was reliant on the skin from the lateral aspect of the knee. And so anyway, so it died in triangular fashion, and so this was a call for a medial gastrocnemius. Workhorse flap for this part of the body. Type 1 flap. It's got a great arc of rotation. It's much larger than the lateral gastrocnemius, and it's based off the medial sural artery. And there is a perforator actually, where I'll show you some other cases. So you can take skin along with it as needed. So this is in this case, I think the aligner replacement was performed, and the gastroc was easily brought up. And it's a very straightforward flap to do. It really does not take much time, and we always skin graft it. And you can see some more cases. I mean, this is a very typically a large, healthy piece of muscle, and really doesn't have any significant, unless they're professional basketball players. This does not have much functional consequence. And actually, over time, like over a period of a year, probably 67% of this will just undergo disuse atrophy. If you need to get further up the knee or even the distal thigh, you can release it for at least on the medial aspect of the knee. You can release it proximally and get probably a good 5 centimeters extra arc of rotation. We have had a number of cases now. Actually, most of them have been with Dr. Agarwal, wherein we have brought the gastroc and we've taken a small contribution of Achilles, a long contribution lengthwise, but obviously not compromising the Achilles from a width perspective, to reconstruct the extensor mechanism in addition to coverage of hardware, both this for distal extensor mechanism, proximal extensor mechanism discontinuity. These actually were tumor cases. We have good post-op video of extension with these cases, and this is actually a proximal quad reconstruction, quad contribution reconstruction with in a similar fashion with the gastroc and an Achilles component. So it's a very, you can really get creative with the gastrocnemius as needed in these cases. And then, as I had mentioned previously, if you really need more than just what the muscle can offer, you can take a big skin paddle with it, with that perforator that I had mentioned previously. So this was a case where where this defect was a small part of the equation. Ultimately, we needed the gastroc to cover the knee itself. And that mid portion of skin that you see there is that skin paddle, and it's very effective at giving like a large area, and really sort of precluding the need for or actually usually precluding the need for a free flap in this area. And I have one more similar case. Again, you can see how much soft tissue coverage you can achieve around the knee with the skin and muscle components. You can even do a distally based flap. Like I showed the ALT to the hip. You can actually distally base the ALT. It does have a little bit of a tendency to get congested, so sometimes you have to augment the distal outflow with an extra venous anastomosis in and around the knee. But this was a trauma case, but also covering the knee area, so certainly could be used for a joint infection. Particularly if you don't have for whatever reason, a gastroc option. In this case, you can see the medial gastroc has already been used. So obviously, this is a much bigger defect than just the gastroc can help you with. So this is the anterolateral thigh flap being brought down, and it provides actually good longitudinal coverage of the knee and the proximal tibia. And then perforators flaps are useful. This has gotten me out of trouble and out of the need to do a bigger flap for kind of smaller defects. So you just have to find an arterial perforator. Have to get lucky. It has to be near the area of the defect. So with a Doppler, you find them and you design basically a propeller shape. These are also called propeller flaps, and you don't have to isolate it, but you do need to sort of visualize it and confirm it underneath the skin that it's there and supplying that little sort of propeller-shaped piece of skin and bring it up and put it into place. Often I'll have the skin graft the donor site, but that's very well tolerated. Similar case, this was for a distal pole defect, also for a joint case. So instead of doing a big muscle flap for a small pole defect, this was an effective the perforator flap, an effective technique to cover that area. And you can actually even do a big, you can do a fairly big one if you have bigger perforators. And this was based off of lateral geniculate system, and so not pretty, but a big flap to cover a big defect with the donor site being skin grafted. Okay, so for the ankle, I'm not going to spend too much time with this, but there's as we all know, it's pretty thin soft tissue. There isn't a lot of pliability. There aren't a lot of random pattern options. There are some axial options. I know that there are not a lot of ankle joints being done, but that being said, and this is not obviously that kind of case, but I do use this to cover the area, and certainly I've used this flap, which is the reverse sole flap, to cover Achilles defects, and so it's based off of the distal branches of the perineal vessels with perforators going along and following the sural nerve. So you do take the sural nerve with this flap. It's fasciocutaneous, but it's pretty quick. It leaves all the surgery, limits it all below the knee. So that's another advantage. And it does provide good coverage to this part of the lower extremity. Small flap that we do once in a while, just for sort of distal fibula and then malleolar and then proximal ankle defects, all laterally, is the reverse peroneus brevis, based on the same perineal perforators I was talking about for the sural, and you just skin graft that. And it's a simple solution. The small defects in that area. And finally, I want to mention SPY, which is indocyanine and green angiography. We actually have this machine now at LOH. It's a dye that's injected and flushed by the anesthesiologist. You turn the lights on, and to turn the lights off, and this machine, you point it at the area of skin. There's a delay phase, and then the skin will light up as long as it's vascularized. There's an arterial phase and then a venous phase. So anything that lights up like this, that soft tissue is going to be totally healthy. So if you're in a situation where you have questionable soft tissue, or if it's dusky appearing, pull out the SPY and in a few minutes you can really get a reliable indication as to whether it's going to survive. And if you have any issues, then obviously, hopefully you will call us ahead of time. But that this is definitely a good indication to call us if the SPY shows dead soft tissue. So in conclusion, without loss of domain, which is usually the case, primary closure is typically possible. Again, barb suture, I think, is very helpful for that. If not, if there's a prior scar, certainly bipedicle flaps can really get you out of trouble. Very simple and buys you, 1 to 3 centimeters. And then again, low threshold to involve plastic surgery. We love working with all you guys. And there are many pedicle options for the hip and knee, and the same thing is true actually of the shoulder. Great, thank you.
Okay, Pierre, thanks so much for joining the call and giving us your expertise. I'd be careful what you wish for, Pierre. I think with that SPY technology, with the obsessive nature of orthopedic surgeons trying to cut millimeters of precision to bones, we're going to start spying every single wound incision that we have and calling you at all hours of the night. So we're looking forward to that part of the puzzle. I can see which surgeons are going to be doing that right now already. We're going to close this out with, ID at the beginning and ID at the end. I think it's appropriate because it really starts and ends with a team approach and a multidisciplinary conversation. And who better to lead us down that road than one of my most trusted colleagues that shares many, many patients with myself and our entire department here at NYU Orthopedics. That's Vin Pham. And Dr. Pham's going to tell us about his journey with choosing antibiotics and managing these patients, which one, how long, all the controversial stuff that he's going to give you crystal ball answers for. So Vin, go ahead.
So thanks, Vinay, for the kind invitation and giving me a topic that is bound to trigger conflict from everybody because it's so there's so many unknowns and so many controversies. I love it. And thanks also to my colleagues for the highly educational presentations so far. It's just phenomenally educational. So as you can probably appreciate, you probably appreciated it before even signing up for this, but you definitely see it after, especially all the very, very detailed, complex surgical decision making and findings that happen in the operating room. Prosthetic joint infection is, as has been stated, a very life-altering diagnosis for any patient to get. The things that have to happen afterwards to manage it are obviously as complicated as you've seen. And so great efforts are taken to prevent these. So when we're talking about post-arthroplasty antibiotics, then we kind of have to think about which stages of the arthroplasty are we talking about. And so I didn't want to ignore the intra-op approaches that are taken to prevent these from happening in the first place. As you heard, my colleague, Dr. Hoffman, leads our institution, our health system in this preventive strategy. It involves all the practices that are promoted by our infection prevention and control departments. It also includes everybody in the operating room, the surgeons for sure, as the leaders in the operating room, but every single person in there, every RN, every surgical tech, the ancillary folks, and it also includes the people who control the environment. Things that we don't necessarily think about: temperature, humidity, all these things matter. Airflow, you don't want dust blowing onto an open surgical bed. Everything matters. So it's much more than just surface cleaning. So then we get to antibiotics. Do antibiotics add anything to all those efforts that are already done to reduce the risk of infection? Now, why are we asking about this, right? It's just antibiotics. Give them to everybody. Give them as many antibiotics as we can, as we have on the shelf. Let's just load it up and try to cover everything we can. Well, the issue is that there are consequences that are unintended sometimes from administering antibiotics. These include things like allergies, but also non-allergic side effects, of which there are many depending on the antibiotic in question. You've heard already some comments about toxicity from certain agents that we use, that we rely on, both intra-op and also post-op. Never forget C. diff disease, which is more than just an annoyance or a troublesome consequence. It can actually be life-altering itself and can even lead to death. And as ID docs, we sometimes have to deal with those most severe cases, and they are terribly frightening and leave us thinking about C. diff all the time. And then even things like drug-drug interactions, as our surgeons boldly try to improve the quality of life of patients with more and more comorbidities. We are seeing patients who come in with very, very extensive, very complicated medication lists, and we have to factor that in when we're thinking about a lot of these antibiotics, because many of them will interact with other medications. So overall, we always have to think, what's the risk benefit of giving antibiotics at any stage in the process, and especially after arthroplasties. Now, when we think about the arthroplasties, we also have to think about what is the surgery that's being done. Is this primary elective arthroplasty? Is it a revision that is done for mechanical purposes? In other words, there's no suspicion for infection. Or is it a revision arthroplasty that is being performed to treat infection? And these are all very, very different in terms of what is going on and what the risk for infection and the potential benefit of antibiotics is afterwards. So let's start with the primary arthroplasties. The questions arise, as the name of this section indicates: which antibiotics do we use? How long do we give them for? So in terms of which antibiotics to use, we rely on very, very limited data and guidelines that unfortunately are already getting fairly long in the tooth. The strongest evidence continues to be for antibiotics given at the time of the surgery. So in other words, intra-op antibiotics, and in particular, given within 1 hour of the incision. to make sure that adequate levels are achieved throughout the body, including the surgical site, and then redosed as needed afterwards based on the pharmacokinetics of the agent in question. The guidelines are summarized in the statements that are listed here. I'm just going to say that for any references that you see in this portion of tonight, if you would like copies of any of these articles, just reach out to me and let me know. I did not put a full bibliography in here. In terms of which antibiotics we give and for how long, the current standard of care continues to be targeting methicillin-susceptible Staphylococcus aureus. These antibiotics tend to also cover strep species. As my colleague Dr. Hockman mentioned, these are the most common causes of infections far and away. Not just orthopedic infections, even looking at other anatomic locations in the body, ones that wouldn't be intuitive, it's these bugs because we live with them. They're a part of our microbiome, on our skin, in our gut. They are there. For that purpose, cephalosporins, and in particular first-generation cephalosporins like cefazolin, continue to be the drugs of choice as long as there is not a history of severe allergy to these agents. The current guidelines recommend antibiotics, like I said, within the operating room. Current standard practice, we know for orthopedic procedures, is to continue similar antibiotics for 24 hours. The evidence for benefit of this is lacking, but it is recognized that this is essentially universal standard practice. My understanding is that there are some multi-center studies that are ongoing addressing whether the additional 24 hours of antibiotics is beneficial. I have not seen any updates on or preliminary results from those studies yet. So the question that we have now before us is, what about even beyond 24 hours? Is there a benefit for even more antibiotics beyond what is currently standard practice? Now, if we look at the primary arthroplasties first, again, what we see is that there are many, many studies out there. Many of them are very small. They're not necessarily all the same methodology, so it is difficult to compare them. But actually, just this past year, a very well-conducted meta-analysis was published and performed. They actually looked at both primary and revision surgeries. What I'm showing you here is their plot for the primary arthroplasties, and taken together, overall, the punchline was there's no clear evidence from the meta-analysis of a need for extended antibiotics beyond 24 hours for primary elective arthroplasties. So that's what the evidence shows. We do realize that among different health systems and even among different providers within a health system, there may be different practices, but that's what is currently supported by the evidence that's available, recognizing the limitations of that evidence. So our go-to is still medications that target MSSA and then secondarily strep, again, because of the microbiology of these kinds of infections. I defer discussions about options for when there is a history of a severe allergy to cephalosporins, but I'm happy to take questions on that later. Now, what do we do when we're dealing with aseptic revision arthroplasty? So in other words, not the primary surgery. It's already more complicated. It's a revision. There's going to be scar tissue. There's hardware there that has to be removed and then replaced. So we're talking a much more complicated surgery already. Is that higher risk? Should we give antibiotics then even when there's no infection suspected? There are many studies looking at this. This is an example of some of the more recent studies. As you can see, the methodology, again, varies to a degree. I apologize for the typo here. That should be knee and hip arthroplasties included in that particular study. The other two studies looked at knees only. The ends were reasonable, but again, sometimes the controls were absent. And long story short, again, if we look at hemolysis before, but this is looking at the respected, then once again, they found no clear benefit. So that said, once again, we do recognize that there is, in this case, a lack of standard practice. In the case of primary arthroplasties, there's general practice universally to give an additional 24 hours. For aseptic revisions, even within a health system, then we often see a lot of variability because of the lack of evidence. So it's a problem that we face in our field in general. I'm talking about infectious diseases. We're not like cardiology. We can't do a randomized controlled trial that includes 40,000 people. So we often rely on what evidence is available based on limitations. So what you'll often find if you talk to your ID doc for recommendations before the aseptic revision arthroplasty is, I'm not really sure. Let me talk to the patient and see how they feel because of the lack of standardization and the lack of guidelines. Now, everything changes though when you're talking about a revision arthroplasty that is performed for the purpose of treating infection. And that's because the question arises, are these patients more vulnerable, more higher risk to infection afterwards? Now, by definition, right, we're talking about patients who we know have an infection. And we also know from every single study that's been done, including on two-stage revision arthroplasties, that the cure rate is not zero. It just isn't. Even among the best institutions, the best surgeons, every intervention taken, the cure rate is not 100%. We know that. So recognizing that there is a non-zero risk of persistent infection, that makes us always worried that we are dealing with a potential persistence in spite of everyone's best efforts. Furthermore, there's also potentially a higher risk for a new infection with a different pathogen, in part because, again, of all the scar tissue, the complexity of the surgery that needs to be done, et cetera. So these are the things that we need to kind of consider. And especially if we're thinking about the risk of persistent infection, then what we're talking about for post-op antibiotics is essentially continuation of treatment for that prior infection and not so much prophylaxis. So looking at it that way, what we see is that there's actually been some fairly robust studies that have attempted to look at this. I show you two examples here because these are considered landmark studies. They're both randomized controlled trials, the highest standard for medical evidence that we have. I should note that both of these studies won the Mark Coventry Award for the quality of their studies. So you in the orthopedics community will appreciate that. And both of them showed overall a potential benefit from post-op antibiotics targeting the pathogen that caused the infection that prompted the two-stage revision approach. And similarly, a more recent study, which is actually a retrospective review, but also included a very large N of patients, seemed to suggest similar outcomes. So what I tend to do for these patients, and again, now I'm not talking about evidence, I'm talking about my own personal preferences and biases, is I ask myself, what is the likelihood that this patient may have not cleared their infection from prior? Some of that is based on the presentation. It's already been mentioned. Signs like a sinus tract is ominous. That suggests chronicity. The pathogen matters, as Dr. Hockman mentioned. Some pathogens are more prone to persisting in spite of everyone's best efforts. And then there are other factors, and this is where I really have to discuss the case in advance with my orthopedic colleagues. What are some of the consequences that would happen if there is a recurrence? For some people, if they're young and they don't have other comorbidities, they might be able to deal better with a potential recurrence. Other folks, if they have a recurrence, it is beyond life-altering for them. It may even be life-threatening. And these are things that I try to factor in the decision-making about risk-benefit. Lastly, we always have to think about, okay, if we want to give them antibiotics, what are our options? And we have to bear in mind, again, the same problems we talked about earlier: allergies, drug-drug interactions, and the susceptibility profile of the pathogen. As was mentioned, some of these pathogens have very, very limited antibiotic options, and that may also put us in a corner in terms of this kind of decision-making. A quick word on oral antibiotics. As many people in the audience hopefully are aware, The landmark Oviva study, published back in 2019, demonstrated that for orthopedic infections in general, antibiotics via the PO route, assuming that they were active against the pathogen that was identified and that they were dosed accordingly, was non-inferior to IV therapy. Now, those are big caveats. So in other words, it may turn out that oral antibiotics are not an option because there are just none available that are for the particular pathogen. That's that susceptibility that we talked about. Big caveat about this study, it didn't only focus on prosthetic joint infection. It included a lot of other infections, including native joint, native bone osteomyelitis, hardware infections related to trauma, et cetera. And they did not break it down into just PJIs. So we can't really extrapolate from that that is necessarily true, but the feeling is that if oral antibiotics are an option, then we consider those long-term risks, allergies, drug interactions, et cetera, and we decide accordingly. With regards to specific antibiotics, I usually think about which ones do I avoid and what things do I think I'm covering. So I never use rifampin or quinolones for monotherapy because of the very, very rapid selection of resistance to those agents. It only requires a single point mutation. And so that resistance emerges incredibly quickly, especially for Staphylococcus aureus, Staph aureus. If I'm dealing with Staph aureus and it's methicillin susceptible, there's a lot of evidence that beta-lactams work. I will not get into discussions about bone penetration and those kinds of pharmacokinetic considerations. I would point out that some of the studies that I already referred to used beta-lactams, including the Oviva study and including the randomized clinical trials that I mentioned as winning the Coventry Award. I also try to avoid side effects. So for example, medications, if I'm thinking about giving antibiotics for several weeks or even a few months, then antibiotics are associated with high risk of cumulative side effects like quinolones again, tendon rupture, a catastrophic event for a patient recovering from an orthopedic situation already, or linezolid with very, very high rates of irreversible side effects with cumulative exposure, things like neuropathy, optic neuritis, et cetera. In contrast, other antibiotics, as long as they don't have an allergic reaction to them up front, medicines like beta-lactams, penicillin, cephalosporins, tetracyclines like doxycycline, or cotrimoxazole, those tend to be well tolerated as long as there's no adverse event up front. So as you can see, it's difficult for me to make a blanket recommendation. It relies on a lot of case-by-case consideration and a lot of discussion with the patients in terms of what their feeling of risk is. So that's it.
All right, Vin. Well, thank you for keeping us right here. We got a few minutes left before our session closes. We're definitely open to any additional questions that come through the chat. I'm going to ask one question to Pierre that came through the chat, but we're going to start with Pierre and just go kind of through the line here. One person asked about knee closure, seeing more of zigzag type incision closures. I don't know if you're seeing that at all. We're not seeing that at NYU, but is there any truth to having a stronger closure if the incision is kind of crosshatched, zigzag fashion?
No, I mean, not that I know of. I mean, the times I see that those sort of decisions are, I guess, if for whatever reason someone had to do a Z-plasty to get there's a scar there that they needed to lengthen. There's a thing called a W-plasty that's done on a much smaller scale where it's zigzag patterns to just reduce. The idea is to reduce scarring, but I don't see anything any reason why it would increase, the strength of a closure.
Got it. Yeah. In terms of one more question for you, Pierre, real quick. In 60 seconds, when do you call it quits? When do you say that we can't? It looked like basically you could reconstruct anything. I'm going to be very vigilant with making sure that we get all of our ducks in a row with our referral base here, because I have a feeling we're going to get a lot of referrals in with things that are maybe not as salvageable as we think. But is there a point where you say, look, this is too many surgeries, the soft tissue is just never going to heal, it just keeps draining. It's time to really think about avoiding limb salvage and going to amputation and
Yeah,
closure.
I mean it's so rare, but we do see it. I think the answer is that I think it's basically the extent of the infection or the problem. And what I mean by that is, if you're talking about an isolated area, the knee or the knee and proximal thigh, we can probably fix that kind of stuff. But the situation that we've been in, where it's a 30-year-old problem and the patient has hardware extending from the hip to the ankle, and they're draining sinuses at the thigh and the pretibial area, you're not going to overcome that. There's nothing you can remove and replace down the road and expect to have any kind of reasonable outcome. I mean, that's, and you have, ongoing osteo and that kind of situation. It's too far gone. I mean, I think once you're beyond sort of a relatively isolated, even if it's large, but an isolated area, I think you get in trouble.
Yeah, yeah. Thankfully, like you said, very few and far between. I'm going to answer a couple of quick questions here. A lot of questions all of a sudden on antibiotic choices. I'm going to kind of go through these from a surgeon's perspective. Same day surgery, 24 hours, you can't give IV. Yeah, we don't give 24 hours of IV. The key take home is that just like in the studies, you give 3 doses to cover the 24 hours. So if you're giving Anzev, that's 2 more doses, for example, maybe of Keflex or something, 1 more dose just to get you to 24 hours of Duracef or something. So you don't give patients IVs at home. That's not happening. Duracep after aseptic revisions. Yes, possible uses. There's actually some data with high-risk patients that are being done with primaries for a 7-day course. But I see Vin smiling there. You want to chime in on that at all?
No, I'll stay out of that. Again, there's a lot of different practice. There's small studies. Some suggest possible benefit. Some are not able to demonstrate a benefit, but as we know, a lack of evidence for benefit is not evidence for the lack of the benefit. So
Super diplomatic.
Yeah.
Super diplomatic. I'm going to just be the orthopedic surgeon in the room and say, yes, we have patients and surgeons that use Duracep after primaries, aseptic revisions. I think a big party line in most orthopedic societies nowadays is that there's really no evidence to support, really long-term antibiotic usage in routine primary cases. So that's kind of been spoken about with Jay Parvizi as well. Body wash prior to surgery. Does this reduce the odds of getting an infection? I think we do a chlorhexidine type wipe, and we do give patients that. It does decolonize, as Dr. Hochman pointed out. Colonization is huge. We also do nasal decolonization. Radiologists looking at MRI suppressive exams to diagnose PJI. We're doing a lot of that at NYU. We really we're looking at a study about that with our radiology colleagues. Haven't come to a overarching conclusion that they've been definitively able to diagnose, but certainly they can look for osteo, they can look for edema, and they can look for loosening of implants, all of which really require high quality machines and really trained MSK radiologists. So not as much luck for my fellows that graduate, go into the community and get their radiologists to try to do MRIs to look at PJI. But certainly I can tell you bone scans, not really useful, definitely not in the first 12 months after surgery. Anything in terms of Armin calcium phosphate beads, which are potentially non-resorbable. I think most of the products, I think all the products are calcium sulfate that you mentioned.
Yeah, calcium sulfate just has the best solution properties, has been used most commonly for them. People have been using PMMA beads in the past, but they just don't have the long-term elution properties that most of us would be happy with to want to use.
Yeah, so I think a lot of questions on kind of intraoperative washes. I think you cover that extensively. There's one question, again, on more same-day surgeries. Does that mean more infections? If you look at the people that are getting same-day surgeries, they're healthier hosts, and lack of comorbidities really favor the fact that they're not getting as many infections, which has been shown in some data from Rothman. Again, selection bias is key there. I think I'm going to respect everyone's time here. Look, it's been 2 hours of fun. We could go out 2 months with this panel. I think everyone wants to get to their families and sleep. So I just want to say I appreciate this. This has been a blast for me to put together. I think the multidisciplinary approach and having these conversations with my colleagues here at NYU are extremely fortunate, first of all, to have them. But second of all, it really helps decrease our burden with reinfection. And it takes ID, it takes orthopedics, it takes plastic surgery, and a whole lot more. And with that, I want to thank all our panelists, and I want to thank you guys for joining us. Have a great night, everybody.
Thank you very much.